every million people in the United States. So in Kansas City, we have about 2.5 million people, so you expect to see about 250 cases a year in this region. It can occur in both children and adults. Usually in children, it's associated with an acute viral illness, and the child will have like an upper respiratory tract infection or a sore throat, and then about a week or 10 days later, the parents notice that the child has a rash, usually on their legs. Takes them into their pediatrician, they do a CBC and find out they have a very low platelet count. Most of the time in children it will resolve without any treatment whatsoever, and it usually doesn't relapse. However, in adults, there really is no clear association with any type of infection. It seems to just to kind of occur out of the blue. And most of the cases do not spontaneously remit, and they do require treatment. And in many cases, the ITP may appear to respond to treatment, but then will relapse later on. We're not really sure why the autoantibodies form, but what we think happens is that the platelet is recognized by the antigen-presenting cells in a person and recognized as a foreign antigen. Those platelet peptides are then presented to the T cells, which then stimulate the B cells to make antibody against your own platelets. And then these antibodies coat the platelets, and then once the antibody-coated platelets go through the circulation, the macrophages that are present primarily in the spleen and the liver and the lymph nodes see these antibody-coated platelets and start to engulf them and remove them from the circulation, and that explains then why the platelet count continuously drops. So this is a disease of accelerated platelet destruction as opposed to those that are caused by decreased production in the bone marrow. There's been a really novel treatment for ITP for about the last 10 to 15 years, and this involves using RhoGAM. And typically we use RhoGAM, which is a product of anti-RHD antibody that's used in Rh-negative women to prevent hemolytic disease in the newborn. But what they found out is that if you give Rh immune globulin to an Rh positive patient, it can actually make their platelet count go back up. And so I just wanted to show you a couple of slides of how that works. The indications for using RhoGAM are you have to be an Rh positive patient, but 85% of the population is Rh positive and 15% is Rh negative, so this works most of the time. It can be used for children with ITP, adults with ITP, and also it can be used for those cases where the ITP is associated with an HIV infection. Usually we use the intravenous preparations, and there's two of those on the market, one called Winro, and more recently a new one called Rofalac, which is the current product we're using in the St. Luke's Health System. And when you do this, you have to monitor the patient carefully for hemolysis and anemia. These patients will develop a direct antiglobulin or a Coombs test because you are coating their red cells with anti-D antibody. In some cases, you will notice a drop in their hemoglobin, and if that happens to a very extreme degree, you have to then transfuse those patients with Rh-negative red blood cells. Well, why would this even work? Well, the first thing to realize is that in a drop of blood, we normally have 5 million red blood cells per microliter. That's a normal red cell count. And a normal platelet count is about 150 to 200,000 per microliter. So you have about, in a healthy person, you have about 20 times more red cells than you have platelets. In a person that has thrombocytopenia, that ratio may be as high as 200 red cells to a platelet. So what happens is, in a normal person, when these antibody-coated platelets go through the circulation, they're picked up by the macrophages and destroyed. But if we coat red blood cells with antibody, what happens is there's 20 times more red blood cells than there are platelets. So the spleen and the other immune organs are actually seeing more antibody-coated red cells, and they get sort of just congested with all these antibody-coated red cells, and it spares the platelets. So shortly after you give somebody Rh immune globulin, within about a day or two, you'll start to see their platelet count elevate, and it'll stay elevated for about 2 to 3 weeks. So in our case today, this patient was given an intravenous injection of Rofalac, and he's actually given a fairly high dose of 75 micrograms per kilogram, and for him that meant he got 6,000 micrograms. And he went home, and then that evening he started having severe flank pain. So he went back into the emergency department of the hospital, and they noticed that his hemoglobin had dropped from 11.6 the day before down to 8.8. The doctor ordered a unit of blood for this patient, but the blood bank was unable to find cross-match compatible blood, and they gave the patient a unit of platelets and then shipped him down to one of our larger metro hospitals. When he was admitted to that hospital, he was found to have still a hemoglobin of 8.6. His LDH was elevated to 400, and his haptoglobin had fallen clear down to 7, and his bilirubin was 3.2. So these were all good indications that he was having fairly severe hemolysis. In the blood bank, they worked him up, and he did have a positive antibody screen, and they identified that he had the anti-D, which came from the ROGAM, but he also had an underlying anti-Duffy antibody, which is probably why the small hospital blood bank wasn't able to find compatible blood for him. So he was transfused with 2 units of O-negative red cells at that time, and that resulted in just sort of a transient increase in his hemoglobin. This slide shows his lab results. You can see that he was admitted on March the 30th. His platelet count stayed decreased and went up transiently to 84 when they gave him that platelet transfusion and gave him the ROGAM, and then it started to drop back down, and it was still low almost a month later. His hemoglobin went up, dropped from 11.6 down to 8.6 on admission, went up every time they gave him 2 units of red blood cells, but then fell back down within a couple of days. And you can see that even on day 14, after he'd gotten this Roflac, we were still detecting the anti-D antibody in his circulation. So he got a massive dose of ROGAM, and it was still destroying all of his own red bloods, his own Rh positive red blood cells, and it wasn't destroying the Rh negative red blood cells that were being transfused. And so we just had to wait until the anti-D got cleared from his circulation before his hemoglobin went back up to its usual level. Well, it was interesting that just about 3 weeks after this case presented to us, the FDA came out and made the manufacturer Winrow put a black box warning on their product, and it warned healthcare workers that intravascular hemolysis leading to death has been reported in patients treated for ITP with Winrow, and that it can also cause a clinically compromising anemia, and that patients should be closely monitored after they get the Winrow for at least 8 hours after administration. And in this case, the patient was given as an outpatient and then immediately sent home. The other interesting thing that's kind of buried in the body of this black box warning is said that patients of advanced age with comorbid conditions may be at an increased risk of developing acute hemolytic reactions such as in vitro hemolysis, in vivo hemolysis. So in our case, what we had here was a patient who had ITP. He got a very large dose of intravenous Rh immunoglobulin, and he did have what I think was a comorbid condition. He had that high MCV, he had splenomegaly, he had abnormal karyotype, and I think he probably really had a myelodysplastic syndrome, and he had these large, abnormal, probably rigid red blood cells that when anti-D bound to them, they were just destroyed at a much more rapid rate than you'd expect in the usual patient being treated for ITP. And then this resulted in this exaggerated hemolysis and caused his flank pain, and resulted in him having to be transfused over about a two-week period. So now I want to switch gears to a case that I entitled